right. So last time we mentioned the thumb sign on the lateral neck x-ray. And then we said epiglottitis, right? That was like a giveaway for epiglottitis. And then I asked you guys what was the microorganism involved in this Haemophilus influenza? Just to emphasize a little more. Haemophilus influenza, you have typable, non-typable. Remember that there are some microorganisms that can protect themselves with a capsule, okay? They can actually utilize capsules to avoid phagocytosis, and that is very important. There's a system of phagocytosis which they are able to avoid. So for encapsulated microorganisms, there is this mnemonic. Even some killers have pretty nice capsules. They're able to avoid the typical macrophage reaction. But what kind of macrophage reaction am I even talking about? Let's say here we have the macrophage, and let's say here we have some kind of gram-negative rod right here. Okay, so what happens? There's two things. It's like ligand and receptor, two things that come into place here. And this is very important because this is the initial first step. It starts off with the macrophage making contact with something called LPS, lipopolysaccharide. So let's be very clear here. The macrophage is the receptor here. It has a toll-like receptor. This toll-like receptor makes contact with something called PAMP. And here, let's say E. coli, for example, it has something called LPS, lipopolysaccharide. Part of the lipopolysaccharide is something called lipid A. And this is immunogenic, meaning that it can react with our immune system. When the macrophages make contact with this lipid A, then you will activate the stimulation of NFK beta, an immune modulator responsible for activating the release of cytokines. And I'll show you guys how that works. But for now, let's just put this original thought into our head. Macrophages are circulating around our tissue. We have macrophages for different types of tissue, and they have different names as well, which is actually significant to learn. Think about this. Macrophages, when they're located in different tissues, we give them different names. So the macrophages of the bones are osteoclasts. The macrophages of liver, the Kupffer cells, like they'll have different names, but they're doing the same thing. They're just macrophages reacting to certain types of microorganisms that they can make contact with. So here I'm just showing you. Hey, if you like what you're seeing, don't forget to hit like and subscribe if you want to see more videos. Also, the notes are free on Patreon. Go to Patreon, download the notes. A macrophage making contact with a gram-negative. Macrophage has toll-like receptor, and it can bind to this PAMP, this pathogen-associated molecular pattern. And in this case, it's lipid A. It's always going to be LPS, but there's one exception. There's one exception that we should know. Which one does not have LPS? Instead, it has something called LOS. Neisseria. Good, good, good. Ding, 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 ding. Correct. Yes. LPS is the typical reaction that we always see with the PAMP. But of course, we have lipo-oligosaccharide, which is Neisseria species, which does have this, okay? All right, so far, I'm just introducing this to you so you could understand what happens. After this binds together, you will have the intracellular activation of NFK beta. Now, NFK beta is usually under the inhibition of IKB. So here you will be degrading IKB and allowing NFK beta to be free. So NFK beta is a transcription factor. It's just going to stimulate the transcription of mRNA for the specific cytokines that it wants to release, right? And yeah, there's a lot of different cytokines here. This is basically macrophage activation. And remember, these things are very important. You have to know what they actually do. IL-1 is provoking fever, right? It can go and actually provoke a fever, increase your body temperature, right? We know that, we understand that. IL-2 helps for proliferation of T cells. So this helps make more T cells, right? It goes inside. Well, we'll talk more about that as well because there's pharmacology wrapped into everything, which is why I love this so much, because there's pharmacology wrapped into all these cytokines as well. Tacrolimus, for example. This is a whole other conversation. We'll get into that when we do more immunology. But right now, we're just seeing the cytokines are getting released. IL-6 has to do with the acute phase reactants. IL-6 actually goes to the liver. So remember that. IL-6 will go to the liver and release acute phase reactants. Okay? Hepcidin and all these things that can sequester iron and can lead to chronic anemia. But that's a whole nother conversation. IL-8 is chemotactic, okay? Meaning that it's going to call over the neutrophils. It's going to let the neutrophils know where this reaction is actually occurring. Neutrophils are blind. They're attracted by chemotactic factors, and IL-8 is one of them. And then, of course, you have IL-12, which will prefer and will stimulate Th1 reaction, right? Th1 favors release of interferon gamma, so you can call over even more macrophages. So what I'm just telling you is that immunology has different types of reactions. If you learn all the reactions, the questions become really easy because you're just sitting down thinking to yourself, okay, which reaction are they talking about? What specific part of the reaction are they detailing here in this question? You read it, you click the right answer, and you move on. So when we do more system-based, we'll do immunology. We'll probably take a week doing that because, yeah, it does take a little while, though, because we have to get all the reactions, the hypersensitivities, the T cell reactions, everything. But for now, all I'm doing is just introducing you to this idea of toll-like receptors reacting to LPS and LPS releasing these cytokines. Okay, so keep that in mind. I would include that in the notes. And remember, if the microorganism here, this gram-negative bacteria, let's say, if it has a capsule around it, it's very hard for this macrophage to be able to react to it. So these things can actually go under our radar. They go undetected, and they can cause complications and really bad infections, right? A lot of meningitis, a lot of these types of invasive type of infections. So remember that. So that's one thing. But just a side note, I should also mention, we mentioned the LPS, and everybody loves the LPS. The LPS is so like popular. But let's also look at gram-positive reaction. What is the LPS of gram-positive? Well, let me show you. Gram-positive actually doesn't have LPS. Instead, it has lipoteoic acid. Lipoteoic acid, that's more of a PAM for gram-positive. So macrophages react, they have a toll-like receptor reaction with lipoteoic acid, right? And it's the same idea, same kind of release, NFK beta, same thing, right? Just let's say the instruments of the immunogenic reaction are a bit different here. Okay, so let's keep jumping around with what we have when it comes to our notes. Okay, so yeah. So something I did include here was the most common cause of otitis media, Streptococcus pneumoniae. Notice that's encapsulated. Haemophilus influenza, notice that's encapsulated, but not this type. This type here doesn't really need to be encapsulated. The non-typable can cause this problem. So let's take a look at this. This here can also cause rhinosinusitis, most common, and it's the same three in that order, right? Rhinosinusitis, sinusitis, same type of pathogens are involved. They're common. This is all in order of common. So whenever I make a list, I like to put it in most common to least common in this way. That way you can stay in your mind, easier to remember. So strep pneumoniae, that is an encapsulated organism. Remember that. Notice that we tend to make vaccines for these encapsulated organisms because we need to have some kind of immunogenic reaction. The fact that it's encapsulated makes it difficult for us to find it, but we can trick our immune system by having like some kind of conjugate type of reaction and then some kind of memory, some kind of IgG towards these kind of microorganisms. So keep that in mind. Continuing, we mentioned the list. So let me take a look at this list. E. coli, strep pneumo, Klebsiella, H. influenza, which we're talking about right now. Right? And let's just keep in mind, if you have a patient who, let's say, makes contact with someone with H. influenza infection, some kind of meningitis, very dangerous. They need to have prophylactic treatment. So the prophylaxis for patients who have made contact with patients with H. influenza, you have to give them rifampin. That's how dangerous H. influenza can be. Okay, so keep that in mind. Complement is used to react to encapsulated organisms many times. You'll see that it stops us from having meningitis. But H. influenza is very dangerous. It has this factor, this H factor that it has. It has a factor on its capsule, which degrades complement. So H. influenza is able to degrade complements. Yeah, factor H. So it can avoid complement as well, which is why it's so dangerous. This is why it's so dangerous, okay? All right, let's continue. Pseudomonas, Neisseria meningitidis, we briefly mentioned this. Cryptococcus neoformans. Remember, yesterday itself, we mentioned some treatments for Cryptococcus neoformans. The treatment that you want to use is amphotericin B, Remember, amphotericin B, they'll call it also amphoterrible. It can cause hypokalemia. Hypokalemia it can cause, okay? Amphotericin B. But we also mentioned something called flucytosine. Who remembers the mechanism of action of flucytosine? Let's see who remembers this. Who remembers this? Anybody remember flucytosine? Yes, perfect. Great. Yes, it does. Yes, it does. It converts itself to 5-FU, therefore inhibiting thalidomide synthase. It utilizes the enzyme cytosine deaminase in order to convert itself into 5-FU. And then, yes, then it will inhibit thalidomide synthase. Good. I love that. You guys remember that. That's great. These drugs are kind of heavy if you think about it. I mean, they're literally stopping nucleotides from forming, and they're destroying the integrity of our cell membrane. It's pretty bad. Amphotericin B, you only want to give this very briefly, right? You give this to the patients very briefly. You follow up, make sure they're doing better, and you switch them off to fluconazole. Fluconazole. You switch them off to fluconazole. That's the typical like management, let's say, for Cryptococcus neoformans, right? Then, of course, salmonella. So yeah, we're just briefly mentioning these, and let's continue because today we have to also do questions. So then I said the treatment for epiglottitis, we mentioned, well, yeah, we said Haemophilus influenza causes epiglottitis. Then we said the treatment, amoxicillin with clavulanic acid. You can also give the monotherapy of ceftriaxone. That can also be used many times if you don't know the culprit. If you don't know the culprit 100%, you can give empiric treatment. You can give a wide spectrum treatment. This is what's recommended. So if you're not sure that this is Haemophilus influenza, ceftriaxone is a really good choice. Okay, because ceftriaxone is wide spectrum, like we mentioned before. Remember, we made a little list of wide spectrum. We said fluoroquinolones, ampicillin, cephalosporins, clindamycin. Ceftriaxone is a cephalosporin of 3rd generation. Something else that I also want to differentiate before we start jumping around here, something else that I did want to also mention is epiglottitis. There's a couple of differentiations, some differentiators that we do need to know as well. So we're just going to mention them today. But further down the line, when we do more micro, we'll get more deeper into the subject, okay? All right, so I'm going to ask you, croup, what is the culprit? Who causes croup? Who is involved here? Can anybody tell me? Type it in if you know. Para-influenza virus is correct. Good. That's perfect, right? Age 6 months to 3 years, barking cough, stridor. They have that hoarse voice, right? Steeple sign, all these type of things. If I ask you epiglottitis, we said H influenza. Epiglottitis, they have this sore throat. They sit down in this tripod position, right? They're drooling. They have the dysphagia, hot potato voice. There's so many different clue words that can jump at you with epiglottitis. But how about bronchiolitis? Who is the culprit for bronchiolitis? RSV. Perfect. Age younger than 2 years old. They have coughing. They have wheezing. These typical presentations. Good. You need to know your differentials, and you need to know them off the top of your head and be able to know them that fast, right? That's a good way. Those are key respiratory tract infection in children. So then we mentioned the mechanism of action of beta-lactams. Hopefully everybody understood what I was talking about yesterday. The prokaryotic cells are consistently making NAM and NAG, these proteoglycan wall structure. They're forming them, and then they're cross-linking it with this enzyme, right? This enzyme transpeptidase is able to cross-link them. So hopefully you guys understand that this is something that consistently happens on the prokaryotic cell wall in order to maintain the integrity. Whenever this integrity is lost, the volume from the outside surface can seep into the prokaryotic cell and then cause swelling, and then it can burst. The cell wall must be maintained at all costs. So, of course, as doctors, let's say, as a pharmacologist, anybody, they want to target its cell wall, and they target it with beta-lactams. Beta-lactams are very popular drugs, right? Penicillin, cephalosporins, monobactam, carbapenems, all this, okay? So yeah, it's the same mechanism of action with all of them. So it's so nice to know this, because if you know the mechanism of action of this, you know like the mechanism of action of half of the antibiotics, basically. And it's so good. So yes, remember that I also mentioned a second mechanism here. It activates autolytic enzymes. So autolytic enzymes will activate and then destroy the cell as well, because you're confusing the hell out of this prokaryotic cell. You're saying, hey, we're destroying This cell wall's integrity is lost. Let's break it down to build a new one. So this prokaryotic cell activates autolytic enzymes, breaking it down, just causing further destruction, basically. Okay, good. Then we send the difference between vancomycin. Vancomycin doesn't really have to do anything here with the cross-linking. Instead, it inhibits transglycosidase, which is basically the union of these NAM and NAG complexes. It's able to inhibit this. That way they don't unite, right? So that's why we can use them. When penicillins are not the best choices, when beta-lactams are not working, there's always going to be options of vancomycin, which is a very powerful drug, right? So that's perfect. That makes sense. And they have a diala part right here. This is diala part right here. And that's where they combined. Okay. Good. And we mentioned already the wide spectrums. I should also mention that PPIs, although they're not antibiotics, wide spectrum, but they can also increase how fast the cell cycle, the prokaryotic cell cycle occurs. So I don't know if you guys remember, but back in the day, we had to actually learn there was lag, log, stationary phase, and death phase when it comes to bacteria. So let's not get too crazy, but I'm just going to tell you this. There was a phase where it was a lag phase, log phase where it starts to grow, stationary phase. This is like the cell cycle of the prokaryotic cells. And then you had death phase. And it consistently repeats itself. And it does this with other bacteria within a colony. But when you have, let's say, too much food available for that bacteria, let's say there's a patient who's diabetic, he's urinating a lot of sugar, he's saturating the urinary tract with a bunch of sugar. He's creating a prominent log phase in order to have a thriving colony of, let's say, E. coli. And that can cause balanitis, that can cause infection, UTI. So if you create the conditions for bacteria to thrive more than microorganisms within its colony, then it will thrive and it will cause an infection. And we can see this with wide spectrum antibiotics, because if I eliminate the other microorganism species, then there's more food for me. So Clostridium difficile, if you give wide spectrum antibiotics, you're inhibiting the other strains that are competing for food within that colony, allowing Clostridium difficile to consume more, to grow more, to have a more prominent log phase. And then Clostridium difficile causes that infection, pseudomembranous colitis. Okay. And we didn't really mention this in the last class, but we should actually mention it now. Pseudomembranous colitis, there's something very important. It can actually have an exotoxin. So it can release a toxin that can cause a type of infection. So yeah, the toxin. Toxin A, enterotoxin, stimulates the recruitment of activation of neutrophils and then induces cytokine release. So this is very inflammatory, right? And it leads to diarrhea. And toxin B is what they call the bad one. This is the cytotoxic one, meaning that it actually is going to try to target the cells in the GI tract, actually causing destruction of that cell, right? Actin depolymerization, which leads to the disintegration of cytoskeleton. Now, I was very, very particular in writing this word cytoskeleton, and I'll show you why later. Because there's a trick here in this exam, and we'll talk about exam tricks a bit down the line, but let me just tell you, if they know that you know that this microorganism can destroy actin, then they can just take it a step back. And instead of them writing actin in the answer choices, they can just write cytoskeleton, because actin forms part of the intracellular components of the cytoskeleton. You see what I mean? So that's their way of trying to trick you. So we have to be above that. We have to actually understand that instead of them, for example, let's say the answer is protein, they'll change it up and say amino acid. Like, you have to understand that they can either zoom it in or zoom it out with answer choices. And that's one way, like, I would say, very crappy way to try to trick you, because you do know the concept, you do understand it, but we've always learned it in the more specific way, actin. So, okay, going back, we were talking about Clostridium. Clostridium difficile. Yes, actin depolymerization. Let me just show you how that looks. This is a saccharomer we're seeing here, right? This is actin. I remember actin because it's the thin one. Myosin is the thick one. Actin is the thin one. So what we're literally saying here is that Clostridium is able to attack this with the toxin B that it has. It's able to depolymerize, basically break this down and destroy the integrity of the cytoskeleton, causing pseudomembranous colitis. That's how it works. Okay? That's how it works. Not to be confused with Clostridium perfringens. Clostridium perfringens goes towards the cell membrane, the phospholipid area of the cell. This is different. This is perfringens. And remember, perfringens has something called, instead of toxin A and B, it has alpha toxin. This is perfringens we're talking about. And perfringens will go and basically break down these phospholipids. It'll break down the phospholipids, leading to gas gangrene. And you'll find this evident in the questions because you could actually palpate the area and you can actually auscultate and listen to presbytus. So it'll sound like crinkling paper, somebody's leg sounding like paper being crushed whenever you auscultate it. So that's very, to me, it leaves a very vivid image in my head. So yeah, there's stupid ways to remember this. I think Clostridium perfringens, let's say, stupid, I know, but women prefer alpha male, perfringens alpha. It stays in my head. As stupid as it is, it just stays in my head. Whatever you can use to make things stay in your head, go with it. That's my advice. Doesn't matter if it's vulgar, sexual, anything. If you can keep it in your head, because there's so many different things for this exam. And we have to grab onto what we can, right? So yes, perfringens, alpha toxin. All right, causing gas gangrene. But Clostridium also has a problem. Clostridium can have spores. Clostridium can release spores. So Clostridium can cause watery diarrhea. Now, I should also mention, side note, there's also something called Clostridium septicem. As crazy as that sounds, yes. Clostridium septicem. We need to know this because it behaves just like perfringens, but it can cause colonic malignancy. It's a Clostridium. This can be associated with colonic malignancy. It travels through the bloodstream. Unlike perfringens, this activates, this is within many people's body, and it actually activates when someone is immunodeficient, then it can actually activate. So that's a whole different thing. It causes colonic malignancy. Remember, another microorganism associated with endocarditis that causes colonic malignancy. Who remembers the name of that one? Does anybody know? Keep going. Let's see. Bovis. Bovis. Yes, it's Bovis. That's the one I'm actually looking for. Bovis. So Bovis has a new name now. For some reason, they're now calling it Galacticus. I know it's crazy. But yeah, Bovis is the one I'm looking for. Remember, Bovis, the combination of endocarditis and the increase in colonic malignancy. So much so for the step 2 people, if somebody has Bovis, they would want you to screen for colonic malignancy. They want a colonoscopy. So basically, alpha toxin, it basically breaks down these phospholipids and it causes gangrene. That's for perfringens. Very, very different than Clostridium difficile, which basically we mentioned, and that what that does is it degrades the cytoskeletal structure called actin by actin depolymerization. Good. So what is the treatment? We mentioned this treatment again, and I'm keep on mentioning it because it's so high yield. What is the treatment for Clostridium difficile? Oral vancol. A lot of people believe, remember, it was oral vancol. So let me tell you, fidaxomicin. Yes. Fidaxomicin. They're loving fidaxomicin now, and I'll tell you why. Between the two, both are very effective. Vancol does work, so much so that if fidaxomicin did not achieve a resolution, then the next recommendation is to utilize vancol. And if you utilize the vancol first, they recommend and you use fidaxomicin. But fidaxomicin is first line only because of one thing, because vancol can target a couple of microorganisms. It's more wide spectrum than fidaxomicin. Fidaxomicin is very narrow spectrum. So if you give fidaxomicin, you're targeting the C. diff infection. And of course, it's oral, right? It makes sense, it's oral because you want to attack directly on the GI tract and not actually absorb it within the bloodstream and break it down in the liver. So that makes sense. So the mechanism of action of fidaxomicin, and this is what we mentioned here in the notes. We said it binds to the sigma subunit of RNA polymerases. Okay, the sigma subunit. So yeah, drug of choice, I put fidaxomicin first, and I put oral vancol here in the bottom. That is how we move. That's how it works. Okay, perfect. So yeah, we then mentioned fluoroquinolones. We mentioned it. We said it inhibits prokaryotic enzymes, topoisomerase 2. That's the DNA gyrase, and topoisomerase 4. What we did not mention is the most common side effect is diarrhea. Don't fall for those tricks. There's certain things that stick out, and basically the tendon rupture is very notable. Everyone, oh, tendon rupture for elderly patients or for younger patients, or tendinitis. But the most common will be diarrhea. Remember that in the question. Very tricky because everybody wants to jump to the most notable type of side effect. And the most deadly, of course, is torsol. It's the point. There was another another antibiotic that causes torsal's point. Who remembers? Who remembers this? Who remembers? The other antibiotic that can cause torsal's point. Type it in there if you remember. Macrolide. Yes. Perfect. That's great. That's good. Yes. Then we mentioned SMX TMP. We got into all this discussion. What we did not mention was dapsone. Let me just tell you, dapsone, although it's not in the family of sulfonamides, it's not a sulfonamide at all. But this dapsone does inhibit dihydropteroate synthase, and it has an anti-inflammatory effect. So they use this for dermatitis herpetiform, right? Those are described as these vesicles that come out in basically patients who have celiac disease, right? So remember that. Okay, we mentioned all these different types of mechanisms of action, TMP, how it all inhibits dihydrofolate reductase. We mentioned all that. And then I mentioned that aminoglycosides and beta-lactams are synergistic. Keep that in mind. I keep seeing questions on this. We talked about long-term dialysis, how it can cause uremia. Uremia can lead to beta-2 microglobulin, right? Mentioned all that. We also mentioned where beta-2 microglobulin comes from. Then somebody asked a really good question about uremic pericarditis. So whenever you have uremia, you start to get uremic toxins. Okay, so typically toxins that would naturally be released and excreted out of the body without any problem. But at the high level of urea, allows these toxins, these metabolites to react. And once they react, they become pro-inflammatory. Okay, there's a long list of them. Good thing you don't really have to know the names of them. There's so many of them. Phenol, they have a lot of different names, but the point is that their reaction is more important, like what they do. And what they're doing here is that they're inducing an inflammatory response to the pericardial tissue. With time, of course, it starts off as a regular type of pericarditis. And as this inflammation, remember one thing about inflammation, guys, one thing that's very important. Inflammation has swelling and it promotes a fibrotic process. So the reason why I emphasize this so much is because a lot of pathogenicity of many different types of disease can be because of the swelling. A lot of it can be because of the extensive scarring. So if I think, okay, inflammation, pericarditis, what happens if this pericarditis just continues? There'll be a time where the fibrosis is just so bad that now the pericardium is not allowed to stretch anymore. It loses its integrity. The elasticity, like I wrote here, is compromised. Then you have constrictive pericarditis. Okay, so let's go the other route. What happens when you have an extensive swelling of that pericardium? It just swells up. Well, then you'll have cardiac tamponade, right? So keep that in mind. You'll see, I'll bring that up as well. Whenever we see inflammatory disease, we'll see that dichotomy where you can split it in two, where it's either a swelling problem, like compartment syndrome, for example. It swells up so badly that now it starts to restrict perfusion to the tissues. Or it could be a fibrotic problem, like some kind of autoimmune problem. And you'll see that it starts off with simple inflammation. but this inflammation gets out of hand. Okay, so keep that in mind. It's best to learn medicine that way, to know your essentials and then just go with that. So this is a good example here. Pericarditis can either become cardiac tamponade or it can go the fibrotic route and become constrictive pericarditis, where the elasticity is gone. That expansion, that elasticity just, it compromises. Perfect. Then we talked about abnormal bleeding when it comes to uremia. Yes, abnormal bleeding is a very dangerous situation where everything there, like the platelets are there, platelets are normal, but they're just not functioning. So you have, in reality, the whole system of this hemostasis where you're trying to make this clot, everything is compromised. And it starts off, of course, with the adhesion. That GP1B receptor is not working. It doesn't recognize a von Willebrand deposition on that collagen, right? Doesn't recognize it. Remember, when you have injury, let's say, the endothelial cells have something called Weibel-Palade bodies. And Weibel-Palade bodies will release the von Willebrand factor. It will also release something called P-selectin. Von Willebrand factor will go on top of that endothelial layer. It's like a Band-Aid, basically. Platelets are supposed to bind to that von Willebrand factor via GP1B. But when you have uremia, these reactions are minimized. Doesn't recognize von Willebrand, so it's going to continuously go in circulation and not reach the site that it should. You also have a problem with platelet aggregation. So you need ADP. Once you bind that GP1B, you have to activate these platelets, right? You activate them, they degranulate. You have release of ADP, binding to PY2 receptors on the platelet. This also, as well, you have release of thromboxane A2, which is important to call over more platelets. Like, hey, we're trying to clot over here. Come over here. But if you have an increase in urea, these uremic toxins are able to decrease the responsiveness of all these types of proteins. Imagine a sandstorm where everything is clouded and all these reactions that occur in the blood cannot occur naturally. So that's a big issue there. And platelet to platelet interactions, I'm just talking about the GP2B3A reaction, where they try to then join up with the fibrinogen. They force the clotting cascade in order to create that fibrin, right? So that's just the other part of it. Okay, so those are the notes that we went through.